you very much. It's a great honor for me to be invited to speak to my colleagues in Zimbabwe, because I'll just sort of give a quick history. I was actually born in Zimbabwe just after independence, and then my father actually trained in Harare, known as Salisbury then, as a doctor, the medical school there, and then he came over here to do specialization in anesthesia. And that's probably a bit of a route that I've gone down, but I am a general dentist. I do general dentistry. I do a lot of oral surgery, but I obviously work in hospital as well. And when we talk about nervous patients, you know, I'm sure you're all grinning there and saying, well, which human being likes going to the dentist? It's very rare to have people coming to visit our speciality of medicine, because dentistry is a speciality of medicine, and them coming and sort of sitting in the chair and just let us get on. You know, the majority of the population don't like, and because they're sort of anxiety and fear of the dentist, it means many don't visit us for, can be many years. And a lot of the patients that I see or get referred are patients who have severe anxiety and phobia, and they maybe haven't been to the dentist for between 15 to 40 years. You know, that's a typical patient I get referred. So we're talking about severe anxiety. But what I want to show you is, as general, what I don't want to show you is what we do in hospital, because it has to translate into your daily work. Otherwise, it becomes a sort of a bit of a pointless lecture, you know. So I hopefully can have some interaction, and feel free to stop me and we can talk and discuss. So I'm just going to put up a quick video, but before I do that, I need to share my screen again. One moment. Okay, I'll just share the desktop. Okay. Right, can you see this? It says Shahabi, Dr. Z Shahabi video. Can you guys see that?
Yes,
okay.
We can.
So I'm going to play and I'm going to talk around it. So this is just our discussion today is about conscious sedation, and I will obviously go on to define it. But I just wanted to show a quick video because of what, you know, we know that pictures speak 1,000 words, and just kind of show you what we do in hospital here. But also, this is something that I do on a daily basis in general practice. So it's not confined to the hospital setting, and that's why I think it's important for us to have this in our sort of armamentarium as a way of helping and assisting our patient cohort. So instead of having to refer them for general anesthesia, you know, then we can utilize this technique, which is very, very powerful. So I'll play the video, and as I'll stop it and sort of talk about it. So obviously there is relevant safety checks. We do an equipment check. We make sure that our we have piped oxygen. Obviously, if you're in a general practice, you can have the normal oxygen cylinders. And this would be for any medical emergency that we may face as dentists anyway. You know, just giving local anesthesia can cause an adverse drug reaction. So we have our general medical equipment there available for any medical emergency. Now, the main drug that we use in conscious sedation in dentistry is midazolam. It's a benzodiazepine which renders the patient less alert to the environment and surroundings. It doesn't give any analgesia or anesthesia, and hence still the dentist or the provider still needs to give local anesthesia for the dental treatment. So we're obviously ensuring that our drugs are in date and the correct medications. We obviously have reversal agents, which allows this technique to be very safe, because as I say, we're not rendering people unconscious. The definition is conscious sedation, and therefore we can use this technique very, very safely in a general dental setting. It doesn't have to be contained to a hospital setting. And that's the beauty of this technique. It's used globally, and even the main sort of pioneers of dental sedation in the United Kingdom are actually our colleagues from South Africa. And they sort of pioneered this in the 70s and run some of the major clinics here and do some of the major training for dentists and anaesthetists and doctors. So we've got a patient here, a special care patient being assessed by our nurse. We're taking the basic baseline assessment here, which will be the blood pressure, pulse, and obviously confirming there are no medical contraindications. A simple pulse oximeter is used to analyze the patient's obviously based on statistics and intraoperative statistics. And then we would draw up our medications, clearly labeled, again, for safety, so we know which is the sedative and which is our saline. And of course, we can introduce other analgesics. We can use very strong opioids, morphine type, something like fentanyl. We can use intravenous paracetamol, which are all very useful in dentistry, especially, you know, someone comes to you with a hot pulp, a root canal that is very tender, they need root canal treatment. But of course, we can utilize it in surgical cases. So patients having wisdom teeth removal, extractions, and of course, these days, with more and more patients going for implant surgery, utilization of all these different modalities through the intravenous line is very useful. So when we teach our students in the special care registrars, we sort of teach them how to do cannulation, because it's not a usual routine procedure for dentists, you know. So we're looking at teaching them the key aspects of cannulation, an aseptic technique, because the intravenous line is where you're going to introduce ultimately your sedative, and it's the beginning of the journey. And we will have many patients that are very fearful of having needles, you know, needles in the arm. And of course, I will talk to you about how we can overcome and what strategies we can use just for us to be able to get the cannula. These are fancy cannulas we have in UK hospitals, paid by the taxpayer. So, you know, they cost about 7 times more than a normal cannula, but they're quite easy to use for when we're training, and generally they're very useful. So this is just showing you, we introduce the line, and then we can introduce the sedative medications, and this will then allow the patient to be rendered less conscious, not unconscious, for us then to be able to provide. You can see this patient now is comfortable enough for us to then provide the local anesthesia and ultimately the dental treatment. So this was just, I wanted to play that video so you can understand where I'm coming from. But as I say, I want to translate this so we can see how this can be used in general practice. And of course, once we've completed our treatment, we ensure that the patient is fully able to communicate with us, and they have clear ability to have motor function. So that we would take them for a walk and ensure that they can combine this safely, so that we can then discharge them with their relevant escort, which is usually a relative member or parent, or, you know, if you're doing it on children. So I'm just going to stop the share for a moment because I need to go to the presentation now. So just bear with me one moment. Great, so let's go to that one. Can everyone hear me? Because I think a couple of colleagues were finding it a little bit difficult to hear me. That may be on your end, but it could be my end. So do let me know if that is a problem. Great, so I've just put up a slides now. Let's have a look there. Great, so as I say, I work in a hospital, but I also work most of my days actually in general practice. So hopefully want to make this very relevant for my colleagues who are working in general practice. So we're going to look at what the definition of conscious sedation is, understand what sort of the indications are. And of course, ultimately, I always tell dentists that I train, it's not only about the patient. You know, you're the one with the drill in your hand that is revolving at however many thousand revs per second. And so if anything happens, if the patient tongue slips, or, you know, you cut the cheek, people will always blame the dentist, but they don't actually understand the environment we work in is very, very hostile. It's not an environment that likes other people involved in the sense that There's a lot of senses, so we have all our senses there, the olfactory senses, the taste buds, the ocular senses. So there's a lot going on. So just generally, it's a very invasive space anyway, as a human being, for another human being to be in very close proximity to your face is challenging. And therefore, when it comes to dentistry, our profession has a lot of stress involved because we're dealing with very complex situation where most individuals don't want us in that sort of space. And therefore, I always tell dentists, well, if you can make your life easier by making it more comfortable for your patients, you're actually making it more comfortable for yourself. And that's reducing that stress level for yourself is a game changer. Excuse me. Especially, if you're practicing this day in, day out for 20, 30, 40, 50 years, whatever it be, it does add up. The stress of the patients can rub off on you. And I'm sure a lot of us know our families feel that affects us as well, obviously. So we're going to see how this assists our patients, and obviously how potentially there could be pathways in the future, hopefully, for you to be able to allow patients to have this assistance. So the provision of adequate anxiety control is an integral part of dentistry. You all know that. You're all dentists. I don't need to teach you that. And therefore, utilizing something like conscious sedation is very useful because it has a very wide margin of safety. And that's the key thing. We're not in a hospital setting where we can call an anesthetist colleague who can then intubate the patient and, ventilate them. We're not going anywhere near there. So it's a continuum from the state of complete consciousness to rendering the patient to a state of safety where they can allow the dentist to then carry out the treatment. So obviously we need to look at the definition, and let's sort of break this down. So it's a technique which you can use. Most of the times a single drug is used, but at times we can use multi-drug techniques to basically render a state of depression, central nervous system depression, whereby the patient's verbal contact with the clinician is maintained. That's very important because this, as we defined, is a conscious sedation technique. And obviously the drugs and techniques we use should be safe enough. So there's a very wide margin of safety to ensure that there's no loss of consciousness. And this is a very known global definition. And I think it's a very powerful definition because it covers all those areas of what exactly it is and how we maintain the safety through this. Because obviously someone entering to this field or someone sort of learning about this field can seem very daunting, challenging, and very scary. And a lot of dentists that I get called to see who maybe have never utilized this technique, or they're calling in as an outside specialist, they sometimes in a state of panic themselves. And we have to manage the dentist first of all before you can even manage the patient. But I think this sort of sums it up. But I'm going to go through some clinical scenarios and cases. So it's a bit like this. You're sitting in a lecture. It's been after lunchtime, or most of you just come from work. You probably got things to do. You want to have your dinner, kids to prepare, homework, blah blah blah. And some of you might be sort of in this state of you might be feeling a bit sleepy. So you're putting yourself in a state of sedation there, but it's a continuum. So from the most aroused conscious state to the final state, which would be a state of deep sedation or unconsciousness through general anesthesia. But I say we're rendering the patient into a state of conscious sedation. So they're conscious, they're breathing for themselves, their reflexes are maintained, the cough reflex, the airway is maintained, but allows them to be in a relaxed state, which then allows the clinician to be able to provide the dental care that they need. So if we go further on, as I say, we've discussed this continuum from a minimal sedation to moderate sedation, moving on to deep, and then obviously general anesthesia, which we'd have our anesthetic colleagues assisting us in a hospital setting. So generally, I like to sort of discuss that good sedation requires very effective local anesthesia as well, because unless you're using a technique of inhalation sedation, which is relative analgesia, which provides some form of analgesia, all techniques, irrespective, require some behavioral management, but very effective local anesthesia. And I find a lot of patients that get referred to us into a hospital service or even in general practice are whereby the patient has had a very acute episode of pain. They may need the extraction, they may need root canal, and the dentist may have started that process. And either the area is too infected, so by them giving the patient relevant analgesics and antibiotics, after a couple of days, this would have assisted quite significantly the patient. So when it comes around to us seeing them, they're actually in a much better state from when they started. So just having your local anesthesia effective and at the right timing is a very key to success, because it doesn't matter how much sedation you give the patient. If they're not numb, they're not numb. The treatment won't work. And I usually find also in very busy clinics, so these are general practice clinics where they're seeing a lot of patients, they have a high turnover. If they're not giving sufficient time for the local anesthesia to work, again, this is very problematic for the patients, because if you look at Malamed, who's the American professor of dental anesthesia, and he's sort of the quote unquote, the Bible of teaching us dental anesthesia, his studies and his work has shown that the peak onset and effectiveness of, for example, an inferior dental block, this is the mandibular block, it takes between 18 to 20 minutes to have full anesthesia. So if someone gives an ID block and waits 2 minutes, 3 minutes, 4 minutes, it's going to start working, but it's not at full pulpal anesthesia. So they therefore pick up the handpiece, the fast handpiece, they start drilling, the patient jumps, they're in pain, they give another ID block. And what's happening is you're sort of overdosing this patient, because all you needed to do was wait a period of time for that initial ID block to work. And now it's not to say that a lot of these patients need extra help. They may need some anesthesia intraligamentally. They may even need anesthesia intrapulpally. How many times we've numbed the patient up and you pick up the drill, it's just too sensitive, and you have to enter the pulp and give effective anesthesia into the pulp for them to be rendered numb. And that's just the nature of the game, and the game we have to play with our patients. It's a matter of time and effective local anesthesia in the right place. Now, when we assess a patient for the safety and suitability to have treatment under conscious sedation, but again, obviously, we look at their medical history. We ensure that they are technically ASA 1 and 2. This is the American Society of Anesthesiology, who defines the sort of the safety techniques for general anesthesia and conscious sedation. So these are patients who are either medically fit and well, or patients who have some mild comorbidity. So they might have blood pressure, they might have asthma, but these things would be generally well managed by themselves and their doctors. And those patients would be suitable to have conscious sedation in the dental setting. Obviously, when you're moving to patients who have more complex medical comorbidities, their diabetes is not managed, their blood pressure is not managed, their airway is not managed from COPD, respiratory problems, then obviously this moves into the higher categories of ASA3. And these are patients that we generally deal with in a hospital setting, because we have the relevant backup there if any emergency was to occur. So we're looking at patients who are generally fit and well, or who have mild systemic disease, blood pressure, controlled diabetes, maybe slightly overweight, asthma, again, all controlled conditions. And we generally treat with intravenous sedation. That's medications given through the veins, individuals who are 12 plus. That's the guidelines we follow in the UK. In America, they have different guidelines. They can treat much younger people in a general practice setting. We do obviously use intravenous sedation in hospital setting for children below this age, but there are obviously much higher risks. And we need to also be very aware that a child is not a small adult. A child has a completely different physiological makeup, and therefore the parameters of them desaturating and becoming unwell in an unsafe setting can happen very rapidly, and hence we follow these safety measures. So with any patient who presents to us, as we discussed at the beginning, many patients hate coming to the dentist. They're scared of us. They don't like the environment. They may have other issues going on. They may have claustrophobia. So there is an element of behavior management that we all do. And then, of course, there is non-pharmacological techniques which you can use. So obviously our communication is very important, making that patient feel comfortable, making that patient have trust in you, feeling safe in the environment they're in. And then there are obviously other psychodynamic modalities we can use, from CBT to clinical hypnotherapy. And that's one of my areas of specialization, is using clinical hypnotherapy in a medical state to assist patients who've had what we call a lot of life trauma. A lot of patients we see who present to us with acute problems, as I say, if they haven't been to the dentist for extended periods of time, many years, they've usually had a lot of life things going on. And without managing those things, you won't truly get an ultimate success for those patients, because they'll just attend to you in acute problems. They won't be able to have these problems treated, their chronic conditions treated over a period of time. And then obviously we're going to look today at pharmacological techniques. So sometimes we can use an oral pre-med. This could be done via a simple sedative solution, a drink, or a tablet, or we can use an intranasal technique. That's a spray that's sprayed up the nose, which works very, very fast and very effective. But these are mainly techniques used in patients who, what we define as special care patients, those patients who can't communicate or who have some sort of neurological dysfunction, where they wouldn't be able to even consent to having treatment. So in their best interest, as the clinicians, we are able to treat those patients with these kind of techniques. And then obviously general anesthesia, as we defined, our anesthetic colleagues would be using in a hospital setting. And then we're going to look at and discuss, and we are discussing, the technique of conscious sedation. So what are the indications? So it's not only about, as we discussed, patients having anxiety. There may be medical indications. So for example, if someone has uncontrolled epilepsy or very elevated blood pressure, then the technique of conscious sedation using midazolam. Midazolam is the medication of choice for patients having epileptic fits. So if you're giving it to them intravenously, then you sort of render that possibility of them having a fit highly unlikely. So we do see patients who, for whatever reason, either had a traumatic injury or a congenital epileptic status, that we can use this technique very safely. So there are medical indications. Of course, there may be very specific phobias, where the patient has a fear of the needle in the mouth. Many patients I see, they're not scared of going to the doctor for a blood test. They can have tattoos all over their body, but the minute you mention a dental needle, they'll run a million miles. So it depends on what their specific phobia is. Some people don't like the sound of the drill. You know, we see a lot of patients who have a very pronounced sensitive gag reflex. They feel like they're going to choke. They can't have anything in the mouth. And therefore a technique like conscious sedation is very, very useful. Again, patients who as children, or even adults, of course, may have had a traumatic dental experience, you know, a traumatic extraction or a traumatic root canal, whatever it is. This then renders them quite skeptical and fearful of going to the dentist again. So a technique like conscious sedation is very, very useful in these patients. And again, patients with complex dental problems, they may not necessarily have a fear or a dislike of going to the dentist, but if they're having maybe a complex wisdom tooth removed, it just takes the, let's say, takes the edge of the procedure for the patients. And again, because through the intravenous line, you not only can give the sedative, but you can give very effective analgesics, which are useful intraoperatively. So while you're doing the surgery, but again, for that post-operative time, that healing period, again, giving intravenous analgesics is very, very useful for those patients, to assist them in surgery. And again, if patients are having implant therapy or any surgical procedure in the mouth, it makes it much more comfortable for them. So I just took some random pictures in the last 2 days. So this was a case we were doing. Actually, it's funny, the the surgeon and the lab technician were both South African colleagues. But this patient was having a lower clearance. We done his upper clearance about 3 months ago. And we used the technique of conscious sedation. He's quite medically compromised. So it was quite a complex case in terms of the anesthetic, but I just wanted to show you in terms of the actual dental treatment. So he was having a full clearance. So you can see the sectional OPG there showing the mandible. So he's got quite a large infection in the lower right 3 area. And you can see that picture at the bottom is after the initial clearance, and the bone debridement and smoothing. And so this patient is having intravenous conscious sedation. It makes it very comfortable for the patient. He suffered from anxiety, so it would be unlikely for him to be able to handle a lengthy procedure. You know, these procedures are 4 or 5 hour procedures, sometimes just for one jaw, depending on the complexity. So there's the extractions, the bone augmentation, the implant drilling, the implant placement. So it makes it very comfortable for these patients. And even after we've done the surgery, then the lab technician has to, you know, make the prosthesis, because a lot of these are immediate loading implant cases. So the whole jaw is loaded with an immediate bridge. So again, that takes several hours. So while the lab technician is working, this patient is generally sort of having a good sleep. And that period of sleep also helps stabilize the clotting in the wound. It makes it very comfortable because they have intravenous paracetamol, opioids such as morphine, we use fentanyl. It makes it very, very comfortable. And the patient generally doesn't remember much because the benzodiazepam we use, the midazolam, gives them anterior grade amnesia. So literally from the time of administering the initial dose till the end of the procedure, the patients generally remember not much. Most of the time remember very little. And they find that quite useful, especially if they have had some sort of fear or phobia of the patient. And this is why these patients are in the state, let's be honest. The reason why their mouths present to us with all this infection and dental trauma is because they never saw the dentist to prevent this. So they're in this state for a reason, and therefore trying to use the same old technique to try and help them just doesn't work. So the types of sedation we discussed, we can give an oral pre-med and oral sedation. I won't go through the differences now. We can use the nasal technique. Inhalation is used a lot of times for children. We use that quite effectively. And again, the intravenous technique, which we're describing now. Contraindications would obviously patients with more complex respiratory problems. COPD can be a problem. Again, patients have to be willing. You know, we have patients that refuse and say, well, I need a general anesthetic, and you know, sometimes that has to be used. Patients who have no accompanying adults, so because this technique renders them partially conscious at times, and gives the amnesia, they have to be legally taken home by someone and looked after for the next minimum 12 hours. So there are a lot of patients in the part of the world that I live in that you know, they don't live with anyone, they don't have any family or friends close by, and therefore this renders this technique, intravenous technique, unsuitable because it's unsafe and we legally can't provide them that treatment. And again, we discuss sort of patients who are having very, very prolonged surgery. General anesthesia may be useful, but we've seen that less and less because we're doing more and more complex implant therapy where patients are having full clearances and upper and lower implants placed with their final prosthesis on the day. And these surgeries, you know, with the prosthetics are 8-9 hours. So it's very tiring for the clinicians, for the whole team, but obviously it's very tiring for the patients. So we're finding that less of a contraindication. And of course, the medical issues we sort of briefly went through. This was the case again yesterday. This patient was having some restorative work. So I wanted to show you it's not only about patients having complex therapy. He needed some anterior crown and bridge work. He had very, very worn down and broken dentition. Again, his fear was he has this very pronounced gag reflex. He feels like he's going to choke. He's going to, you know, he can't breathe and swallow when he's at the dentist. So for many years, he didn't attend. And his sort of partner convinced him, I think they're getting married quite soon, so she was very keen for him to look presentable at the wedding and have the nice wedding photos. And we see that a lot of times when there's a real life event happening for the patient, they sort of pluck up this courage just to come to see the dentist, but they haven't got that enough courage to have the dental treatment with just local anesthesia. So using this technique of conscious sedation, we were able to then make him very comfortable, very safely. And he went on to have and these crowns were just fitted literally yesterday. I took the photos for the presentation, but he's on a long journey. He needs a lot of treatment. His posterior support is completely collapsed. So they're increasing the OVD, increasing the facial dimensions, and he will go on to having posterior implants because he has no posterior teeth in certain areas. And so we're building him up. There's a time and a place. We give the patient a positive outcome to start with, something anteriorly where they feel comfortable, they feel good within themselves. Because a lot of these patients have a lot of social anxiety because they can't smile, they don't open their mouths. Some patients find it very difficult to get jobs because dentition is in such a bad state. So giving that confidence, making them feel good, allows us then to go into the more complex treatments like implant surgery in the posterior areas, and makes it easier for them and of course for us as the treating clinicians. I'm not going to go too much into the medication side of things, but we use drugs generally that are reversible. That's why they're safe. And when you going into using drugs such as ketamine and propofol, obviously this is rendering the patient into a much more deeper water, and therefore we work with anesthetic colleagues quite closely with these cases. But utilizing a technique of using fentanyl and midazolam as an example works very, very well. They work synergistically, and it proves very, very powerful in surgical cases and patients who've got very, very acute hot pulps. Okay, the other technique we utilize is inhalation sedation, used on adults and children. We sometimes have to use it as a primary technique for patients who have severe needle phobia, just so we can get the cannula in. And then once we have the cannula and we introduce the intravenous medications, we can then take this apparatus off. But again, utilized very, very successfully in pediatrics. I'm not going to talk about that technique too much because that's not the point of this lecture. I wanted to just touch base on clinical hypnotherapy again. Hypnotherapy is a state of mind, so you're taking the patient into a very, very relaxed state. And I use medical hypnosis for my patients, and it's a very powerful technique, especially for patients who, what we described as having a lot of life events. And we can utilize this for them to be able to, first of all, just sit in the dental chair, have an examination, and then it can allow them to eventually potentially have a technique of conscious sedation, or even a technique that we're trialing, and we're sort of hopefully it's been used globally, but we're pioneering it more and more in dental use, is the technique of hypnosedation, where you can even reduce the amounts of sedatives you give patients just by taking them into that subconscious part of the mind where all the memories are stored, and help them to relive maybe a traumatic experience in a more positive way. If that was obviously a dental issue, for example, a traumatic extraction as a child where they didn't feel they were numb. So obviously that it's a sort of a PTSD, they describe it. Or even as an adult, someone has a traumatic extraction or root canal. This gets implanted in the memory bank of the subconscious mind, and therefore tapping into that, we can use a technique like clinical hypnotherapy to very powerfully assist patients to move forward. And we usually find it doesn't only assist them in the dental world, and they're moving forward in their dental life, but it helps them generally as human beings, because especially patients who suffer from generalized anxiety disorder, depression. There's a lot of mental health issues that we face globally, I feel. Obviously, it may be more or different statistics globally, but in the West where I practice, a lot of patients unfortunately suffering these things for whatever reason, and therefore a technique like this can be very useful in helping them as human beings. Of course, we expect the patients to have been fasted for a period of time. Even though they maintain their reflexes, we don't want them to have any issues of having vomiting or rendering the airway unsafe. They need to have an escort or relevant chaperone to take them home. And of course, depending on what medical issues they have, we want to ensure that they've had their relevant medications as normal, or we may adjust the medication. So for example, if someone's having full mouth clearance and implants and they're on blood thinners, we may adjust the dosages and timing of those things to make it surgically feasible for that patient to have prolonged surgery in a safe manner. So I obviously appreciate that there's no service for intravenous sedation in Zimbabwe, and correct me if I'm wrong, but that's something we'll hopefully be looking at in the long run. One of my aims and passions is to work further in Zimbabwe, because it's close to my heart, and hopefully see if there's some way we can provide such a provision, whether it's in the hospital service at the University of Zimbabwe or outside their service. I'm just going to stop the screen share for one moment, and I'm going to show one further video, if you can allow me. And it's just to show you, I wanted to just show you the technique of intranasal sedation. Is very, very useful and very, very powerful. So I'll come back on here and let's share the screen again. Okay, can everyone see this video coming up now?
Yes, we can see the video.
Thank you. So this is a special care patient. This is a patient who obviously I appreciate wouldn't be able to be treated in general dental practice. And we're going to use the technique of intranasal midazolam. So this is the same medication that we give intravenously through the veins, but it's at a very, very high concentration. And we use a special atmospheric device, which I'll show you, that we basically squirt the midazolam at a very, very high concentration up the nose. And we all know the nasal, the nasal cavity has very high capillary filtration, and therefore the medications are absorbed into the intravenous system and to its effective position in the brain, into the GABA receptors, very, very fast. So this is a very good technique that we can use, which then allows us to cannulate this patient, because this patient wouldn't allow or wouldn't be able to cooperate for us to put an intravenous line in, and therefore we can then use the intravenous line to administer the sedative safely. And a lot of these patients, of course, they can't speak, they can't talk, and therefore just for us to be able to do a clinical examination, we need to sedate them to find out what the problem is, because it's usually a family member or the care home or the parent would say, for example, this individual is touching their face for whatever reason more than they usually would, or they're not eating properly, they're not drinking properly. And that can obviously indicate sometimes oral pathology, but you can't examine these patients, so we have to sedate them just to examine them. So there's my colleague. Very quickly, you can see she's getting in there with a special device, and she squirts the high concentration up the nose. Obviously, this patient, it takes about 8 minutes. You can see he's sort of becoming quite sedated now. You can see he looks sort of quite what we describe as being very, very relaxed. For us then, for us to then, sometimes we have 3 or 4 clinicians with one patient. One needs to hold the hand. Then you can see one is placed in the cannula. And then obviously once the cannula is placed, a lot of times we can't do the baseline checks on these patients. We can't take a blood pressure on this patient, they wouldn't allow it. So we have to be very effective and very fast to put the cannula, then give the initial dose of a sedative just to render them more cooperative. And then of course, do all our safety checks at that time. And then do the dental examination, and you can see this patient is having scaling. He's obviously had his examination, and whatever treatment we need to do. There are obviously patients that have very complex medical issues, and we're unable to do this technique, and therefore we do need to take them for general anesthetic. But I'm seeing more and more patients who have what we define as special care patients in general practice that require this technique. And because it's so safe, we're able to provide this in someone's dental practice. They would invite us in and say, we've got a patient X, Y, and Z, need some help. And then we can allow the dentist to carry out the examination. And we obviously consent to be able to do whatever treatment is necessary to get this patient out of acute oral and dental problems. So successful outcome, patient obviously looks quite chill there, quite happy. I think we're gonna have some questions now, so I'm just gonna stop the share. I'll put my video on again so you can see me. Great, so please feel free to pass through the chair or through the chat, however you like to do this. I'm happy to take some questions. And we do actually have one question there. Shall I take that question?
Yes, you can. I saw the question in the chat. Yes.
Thank you.
From Dr. Ismail.
Dr. Ismail has said, can this technique be used for patients with Down syndrome? 100%. We use it all the time. We use it very effectively. Again, depending on the level of cooperation, probably we'd need to use an intranasal technique first. So using the atmospheric device to render them partially conscious for us then to be able to use the intravenous technique. So 100%, we use it all the time, and it's very, very safe. Now, do we routinely run oxygen? No. I mean, some clinicians in hospital, whereby they're taking the patients into what we define as a deeper sedation, because naturally their oxygen level, the saturation would drop, and they just want to get on with the dentistry. Then they'd run a nasal cannula for the oxygen. But I generally don't find we need to, and in general practice, it's very, very rare that we do that. It would only be, I feel, I would use it for a patient whose saturation was dropping, and maybe they were deeper for whatever reason. But otherwise, we don't run oxygen routinely, because the whole definition of conscious sedation is for the patient to be able to maintain all of their reflexes, and one of them is obviously maintaining their oxygen level at a sufficient level that is safe for them to have their dental treatment. So thank you for that question, Dr. Manana. Good to have you here. And obviously with Dr. Manana, he's doing obviously more complex surgery. So even other colleagues who are doing, seeing patients who are nervous to the dentist or having, as we discussed, more complex oral surgery, wisdom teeth or other oral surgical procedures, is a very, very useful and powerful technique to help them. So Dr. Chironga, there used to be a need for anaesthetists for these procedures in the UK. Yeah, so I mean, since my practicing life, I mean, I qualified in 2002, and when I was taught as a dental student, we had a sedation clinic, and there wasn't any anaesthetist. That was 20 years ago, and I think the Society for the Anesthesia in Dentistry has been practicing for a long time. So I think when the anaesthetist becomes sort of quote unquote more mandatory is if you're using an infusion with propofol, but we do have dentists using that here as well. I suppose it's like with anything, with if you've got sufficient training, and you can justify if something goes wrong, then you can almost do anything, apart from a general anesthetic, obviously in general practice. But we use infusion lines. There's a new drug we're actually testing at the moment, which I'm part of the trial in general practice, and we'll be trialing in hospital as well. is an offshoot of midazolam called remimazolam. And basically the positives or the pros of this new drug is that it has a very short half-life. It has a very peak effect. So midazolam, its peak effect from administration is about 10 minutes, 8 to 10 minutes, whereas remimazolam is 2 minutes, 2 to 3 minutes. So its peak effect, the patient is very, very sedated to a comfortable level in a very short period of time. You're almost halving the time or even more. And its elimination is, its sort of half-life is only about 20 minutes. So it's very useful in very short cases. So you're doing a quick extraction, wisdom tooth or any tooth, patients in and out, they're comfortable to go, within 45 minutes, half an hour sometimes. And, you can do very quick cases like that. So it's an interesting one. And we're even looking at using that as an infusion for long cases. And the great thing about that one would be, for example, if you're doing a 4, 5, 6 hour case, is you could technically do, let's say the patient's having a full clearance in upper and lower implants. You could do one jaw, patient could be up and about. You could give them some ice cream, let everything cool down, give them some water. They could go pop to the toilet very safely, back in the surgery in the afternoon, put the infusion in, and there you go, ready for the next jaw. So there's a lot of pros with that, but we're going to be trialing the infusion soon. So Dr. Manan, said it would be good to share the minimum requirements set up for a sedation unit. Yeah, I think that's a pertinent question. It's an excellent question. I don't think I'll be able to answer it all right in this second, but I think if we look at the first thing is going to be if a sedation unit is set up, for example, at the University of Zimbabwe, then the minimum requirements would obviously be relevant training for the clinicians involved, relevant training of the allied healthcare staff, that would be the nurses, and of course the actual physical setup, what you need is probably less than what you're thinking. Because if you think of it, I have a backpack. I literally have a backpack which I get called to a surgery. I go to there, they have their oxygen, they have their emergency drugs. I've obviously got my relevant reversal agents, my airways, my sedatives, my analgesics, my cannula, so all those things I can carry in a rucksack. So if we've got a dedicated room with a relevant dental chair, because you could see that's what we do we don't have a theater environment when we're treating patients under conscious sedation at the hospital where I teach and work at. We have a dental chair. We have piped oxygen, but that's an advantage obviously in a university setting. In terms of Dr. Constance, and this leads on from Dr. Manana's question, is what is the minimum training? Well, in the UK, the minimum training is to have 20 supervised cases. So you have your training in sedation. So obviously you're learning pharmacology, the physiology aspects, the sedation training, which would be classroom based, or during COVID, a lot of it was done online. And then physically, you have to have a mentor, an approved mentor. So I'm an approved mentor for the Royal College of Surgeons. So dentists come to me for training, and we do 20 supervised cases. And we feel that 20 is a minimum number. It allows you then to be confident then to go into practice and provide what I would say basic and minimal dentistry with this technique. Meaning you're not going to do 20 cases and then going to be out there doing full mouth clearances and upper and lower implants under sedation. Impossible. It's not allowed. So you're looking at some basic routine restorative dentistry, some basic oral surgery, because you need to be confident to be able to manage to. So operator sedationist, which is what I am. So I operate and I do the sedation 1 day a week. That's allowed with relevant training, and I can use multi-drug on that. But for most of my work now, when I'm working with a clinician, so whether they're doing routine restorative dentistry, I showed you a restorative case there, whether it's an endodontist, whether it's a periodontist, and I sedate for maxillofacial surgeons as well. So maxillofacial surgeons who are doing complex dental rehabilitation, with oral implants, then I'm the sole sedationist. I'm not involved in the dentistry, but I'm there managing the pain of the patient, the pain management. I'm also working with the surgeon in effective local anesthesia. We have a preoperative workup, we have an intraoperative plan, and then we have a post-operative analgesic plan and care plan for that patient. So I'm involved in all those stages for very, very large cases. So yeah, training would obviously have to be approved, and we could try and work with the Royal College of Surgeons to work with that. And I say I'm quite keen to work with the University of Zimbabwe and colleagues. When Dr. Manana knows that quite well, and Dr. Fiona Makoni. I'm not sure if she's probably not on this call, she's so busy, but hopefully she's been a great asset and is going to work with us. I was glad and able to meet her when I was there in August. The next question was, what is a better sedation option if one sees children aged between 3 and 6 needing essential treatment? Okay, so children under 12 in the UK, there are only 2 or 3 centers that are allowed to do this because they have anesthetists doing the sedation, but they basically got a setup where they almost got an ITU facility, because the risks obviously with treating children, they define under 12 years old, is obviously the risks and complications are much higher. Therefore, those patients would generally be treated in hospital service. There's no way we'd be looking at setting up a service for 3 to 6 year old with midazolam, but 100% I treat lots of kids. I treat lots of 4-year-olds, 5-year-olds, 6-year-olds, 7-year-olds, and I treat adults with nitrous oxide. That's a fully acceptable technique. It's a very safe technique, but there's a time and a place, because a child obviously has to be able to cooperate breathing through the nose. And it's sometimes very difficult for the 3-year-old child to have their mouth open and breathe through the nose. So we generally start up from 4+, but it's a very, very useful technique and a very, very safe technique. And we utilize it all the time. And I think for children that age, it's a technique that is used, I think, in the States very often. It's not a technique used in a lot of countries, but I think it's a very safe technique, and definitely a technique that general dentists, you don't have to be a specialist, general dentists doing dentistry on children, if you've got a passion for that, very, very useful. And we know how troublesome us as dentists treating those kind of cohort age of patients in general practice is. It's not very complex. So a technique like nitrous oxide with, again, relevant training. So the training requirement in the UK is 10 cases. It's half of that of the intravenous cases, with a relevant mentor, trainer, to be able to sign you off and say you're safe enough. Obviously, with inhalation sedation, it's a lot more complex. You can't walk around with a backpack and rock up to people's surgeries. But if you're setting up in your own surgery or having a dedicated service, I think that's the best way to start something like that. It's having a dedicated service that has relevant specialists or dentists with specialists. They have a thing in the UK where you don't have to be a specialist formally. You can be what's called a DWSI, a dentist with a specialist interest in oral surgery, pediatrics, periodontics, endodontics, and having, because everything has to be fixed. You have to have your gas, obviously, cylinders, the oxygen and nitrous oxide, whether that's plumbed in through the wall or at a separate dedicated unit, that's relevant, but you can't walk around with these things. So there's a lot of ways that this can be done, but I think working with colleagues, obviously myself, I'm very vested. I have a vested interest to help my colleagues in Zimbabwe. That's why I'm doing this talk as well. But I'm sure I can work with my colleagues at the Royal College and see how we can potentially set up. But introducing a whole brand new system into a country will require time, and it will require initially setting this up in a university environment, because that's the most safe environment with relevant colleagues. And I think once that's set up, then our further aims and objectives can be met, moving this out potentially into general practice. But it will probably initially start off as a an initial referral service potentially. But the inhalation one could be looked at in general practice, again, with colleagues who are either specialists in pediatrics or colleagues who treat children. You know, it's not saying you have to be a specialist, but I think, like with anything, there's a time and a place. So I hope that's answered some of your questions. I know, Wayne, we probably got a lot more to talk about, but it would be it's a great honor to be here with my fellow colleagues. And if there are further questions, if the convener could just maybe sort of say how much time we've got left. It's coming up to 5:30.
Yes, I'm not sure if there are any more questions. We don't have much time. Did you still have any more slides?
No, I mean, that's I wanted to give and it's an introduction to, it's not a teaching course on how to do intravenous sedation or conscious sedation, but it'll be good to see if there are any further questions from any colleagues or anything they want to discuss, because, you know, like I say, a lot of times I'm called to see patients to sedate them when the problem was actually the local anesthesia was ineffective. So the basis of our whole existence as dentists is local anesthesia. And without effective local anesthesia, you can't treat your patient. So I find a lot of my teaching in time now is teaching maybe not only colleagues who, I'm talking about colleagues from university graduates coming out of dental school to colleagues who've been practicing dentistry for 40 years. You know, effective local anesthesia is the key to success, because this is, again, a conscious sedation technique. And especially with children, if you're using nitrous oxide, your local anesthesia has to be on point, because if you cause them any pain during the sedation with the nitrous oxide, you've gone back 50 steps, and they'll just rip the mask off and they'll jump out of the chair. So using effective topical analgesia, and I find, I don't know what's the technique in Zimbabwe, but in UK they use a lot of lignocaine paste, and I think it's a complete waste of time. It doesn't do anything. I think it's a complete placebo. So we get this little pop from America I buy. It's not cheap. It's about, say, $20, whatever. But it's benzocaine solution, like a liquid, and just a small amount of that onto the gingiva and the soft tissues creates sufficient anesthesia for you to be able to use your anesthetic technique. And we know, having warmed anesthesia using a buffer solution in acute cases of infection, and giving your injection very, very slowly. Now, they sell this fancy pen in the UK. It comes from America, Septodont. It's just like a little pen which you put your local anesthetic cartridge in, and you put your needle in, and it costs about $3,000. It's probably about, I don't know, pounds to dollars, say $3,500. It's very expensive. I don't have one personally, but there are colleagues that use it and they swear by it. But all it's giving is the anesthesia very slowly, and that's what I do. If you give your anesthesia very, very slowly, if you give sufficient buccal infiltration, let that work. For example, you work in the maxilla, and then you give intrapapillary injections, you can almost numb up the palate with that. And then therefore, when you give your palatal injection, which we know is the most traumatic for anyone, even for us, it would be painful. Patient doesn't even feel it, you know. And using techniques of distraction, using the opposite end of your mirror. So I pretend this is the dental mirror, this is the mirror side, and this is the opposite end. I place that in the soft tissue palatally for at least 30 seconds. You've got to see blanching. And then you introduce your local anesthetic needle, the patient doesn't feel a thing. You know, so giving effective local anesthesia is, for me, 90% of the battle, and the conscious sedation is 10% of it. But I say it's a very useful and powerful technique. Right, we've got a question from Dr. Sheetal Bashkar. Nice to meet you. Can you elaborate on the effectiveness of antibiotic therapy prior to extraction RCT for more effective achievement of local anesthesia? Medical colleagues may advise against it. 100%. I agree with the problem of overprescribing, and there is a problem globally. We have antibiotic resistance, which is causing real damage to us as human population. I think your question was answered itself, really, is that the regime of antibiotic therapy has to be relevant to the case. So of course, I'm not going to sit here and say, yes, everyone who needs root canal needs a box of antibiotics. Of course they don't. But obviously, a lot of times, the patients I'm seeing are patients who have seen another dentist. They've have an acute problem, or they presented to me with an acute problem. I see a lot of dental emergencies. And when you try and give a local anesthesia, for whatever reason, it doesn't work, because they are they've had a chronic infection that is now blown up acutely, and therefore they may need a course of antibiotic therapy to reduce that bacterial load. So the anesthetic is then effective. But a lot of patients I see are in so much pain, they've literally haven't slept for days. I can't then say, well, okay, here's another, here's a packet of amoxicillin, take that and see me in 7 days, because they're in acute pain. So a lot of emergency patients I see utilizing sedation is because they've got that acute flare-up of a chronic problem, and therefore utilizing a technique of intravenous sedation where I'm not just giving sedatives, but I'm giving intravenous opiates such as fentanyl. Remember, these things are working centrally. So we give preoperative 800 milligrams ibuprofen. This is for a very acute case that I'm going to see there and then. Then I can give intravenous sedatives, intravenous paracetamol, intravenous opioids, and then giving sufficient time for the local anesthetic to work. Because regardless of how infected the site is, the anesthetic will work eventually. It's just how long do you want to wait for? And like we discussed, of course, there are going to be times when even you're doing an extraction, the patient may need intrapulpal anesthesia. Intrapulpal anesthesia is not only utilized for patients who need root canal. I do it all the time. If the patient has an acute infection, they're not getting numb because the anesthetic is unable to penetrate and work in the area because of the infection, then you have to give intrapulpal. And if you have to give intrapulpal, it's painful. And giving it to a sedated patient who's not going to remember that, it's a win-win situation for the patient, and of course for you as a clinician, because none of us wake up in the morning or went to dental school so we could intrapulpally inject people and give them pain. We never did that. So it's traumatic for us. When you're giving anesthesia and you're trying to take out a tooth or do root canal or extirpate, and the patient's in pain, it's affecting you as a human being, because you didn't set out that morning to hurt people. You're there to help people. And like I said at the beginning, it's traumatic. Forget about the patient for a minute. It's traumatic for you as a human being. So that's why this technique is being used more and more and more and more. The last 20 years, it's skyrocketed the use of conscious sedation in the UK. But in summary to your question, there's a time and a place. Of course, if you can't get the patient numb and, the patient isn't numb and you can't do the treatment, then of course you may need to prescribe them the relevant antibiotic regimen to reduce that acute infection. So then you can assist them and treat them in whatever way. So I hope that answers your question. I'm not a specialist by any means in infection control management, but I deal with patients day in day, and just like you do it as general practitioner. And of course, 100%, I think the like you said, it goes down to back to basics always, especially with local anesthesia. In what we do, it's mandatory, and I find even patients who I sedate and the dentist or surgeon hasn't given sufficient anesthesia, I'm guiding them that actually your patient's not numb. They don't need more drugs from my end. They need more sufficient anesthesia. And if you're doing an 8-hour procedure, of course, then you have to, you have to be very controlled and safe in your manner of giving for, local anesthesia toxicity and timing. And we even give very effective anesthesia at the end of surgery. So then that allows the patient to have a period of anesthesia post-operatively when you've just had your whole mouth worked on. It's not a joke. And I was going to mention something that's just completely slipped my mind, but Great. Is there any further questions? I appreciate this is just an introduction into this topic. It's not a be all or end all, and I would be really honored to keep this discussion going and having other colleagues. We can work together and look at other topics together, and it'll be really great. So thank you for your time and thank you for listening. And I hope that was useful, and do provide feedback. It would be great to get feedback from colleagues and see how we can work together for the future. I do have other topics, but I can present them to the committee who decides on maybe future CPD work.